Hi, welcome for this first plenary session of the EMA 2021 annual conference. This plenary session is dedicated to discuss shaping health systems for a post-COVID world, and I will be your host for this plenary session, and my name is Alexandre Lourenço. Gratefully, we have four amazing speakers with us today that will discuss this topic. Actually, I will also invite you to use our chat box to make some comments, questions to our speakers, and feel free to do it during all the plenary session. This year and a half, these 2 years, were mostly dealing with an emergency situation for health systems. We may say that Europe coped and responded with, of course, all the fragilities in different countries, but we coped, and the systems actually, they respond to this pandemic. Even for the ones that followed our opening ceremony, one of the things that we need to discuss, and actually are going to discuss during this plenary session, is how to use this learnings, this window of opportunity for not go back pre-COVID times. And I'm gladly moderating the session with these four amazing speakers that will allow us to discuss and to know how we can really shape health systems in this post-COVID world. So this session will last 75 minutes. And you are welcome again to use our chat box to make comments during all the session. I welcome Adelina Comas Herrera, Mauricio Teccioni, and also our long-term partner, Ellen. So I will welcome you, and I will now give the floor to Dr. Hans Kluge, that is the director of the Regional Office for the World Health Organization. We are having some problems with the sound from Dr. Hans Kluge. I believe that our colleagues in the back office are trying to solve the problem. Let us give us just a few moments, and we will get the message from Dr. Hans Kluge. Actually, let's see if it's working now. Yeah, maybe we can come back, and maybe we can move forward and try to listen to this message from Dr. Hans Kluge after listening also to our panelists. And I would invite immediately Professor Maurizio Teccioni, that is the president of the European Society of Intensive Care Medicine. He has been in forefront and is represented the forefront healthcare workforce during this COVID times, and he will talk us about this during 7 minutes, his comments on this after COVID times. Professor Maurizio, the floor is yours.
Thank you, Alexander, and welcome everyone. Hello also to the other panelists, and thank you to HMA for putting together this conference. I think it's very important that despite all the Zoom fatigue that we all have, we put the effort and energy to stick together, because I think if there is a legacy from this crisis, is really how the clinical, scientific, and I would say policy community got together really for the greater good. And I hope that we will not forget this. I represent the intensive care medicine community. I'm an intensivist. I work in Milan, but I also worked in London for many years. And I'm going to share in these few minutes my reflections on this pandemic, which I think are the reflection of the community that I represent. I have just a few slides to share that will help me with some data, and will make it easier probably to explain what we were facing, especially in the first days of the pandemic. If you remember, on the news, on televisions, everyone looked at the first time in intensive care. I've actually done the same job for 20 years now, and what you've seen in terms of patient treated with mechanical ventilation, patient treated with proning, which is when they were put with the belly down to improve their oxygenation, all looked very new to the world. But the reality for us working in intensive care, that's what we've done always for patients with severe infection, with severe pneumonia. What has been unprecedented for us, and it's where we were not really prepared for a tsunami of this magnitude, was really the speed at which patients were coming to our intensive care unit. I happened to be in the first big outbreak outside of Wuhan. I worked in Lombardy. You may remember the first days where the world was watching us and you were seeing our hospitals overwhelmed with admissions. This unfortunately has become the case in many places of the world. And I think in this slide, which is the mathematical model of the possible admissions to ICU that we would have had without public health measures, then you could see that we could have ended up in the region where we had only 850 beds to start with 14,000 admissions to intensive care just in a few days. So this would have not really been, would have not been able to manage this in any way without public health measures. And I think this is my key message. Intensive care units are the last line of defense. But really, we need the help of citizens. We need the help of public health measures in the community to be able to care for every patient, not just for COVID patients. At the beginning, everyone was looking at ventilators and personal protective equipment. It is true that at the very beginning there was a lack of that, but that's something that over the first weeks we managed to either to produce or to manage to procure in our hospitals. What you cannot procure, what you cannot find just in a few days or in a few weeks is actually experienced healthcare workers. Experienced healthcare workers and competent healthcare workers is not something that you can create in a couple of weeks. It takes 5 to 7 years to become an intensivist. It takes a couple of years at least for a nurse to become a specialist nurse in intensive care. These competencies is not something that we can multiplicate just by adding ventilators and beds. And this has been the biggest crisis, and where maybe at the beginning there was not enough focus from the institutions. However, as a community of intensivists, we were very pleased that, for instance, the European Commission came and spoke to us and asked our expertise and our knowledge through the network of our intensive care units in Europe, asking, what should we do in case of a second wave in the autumn? And we were very pleased that they asked our help, and we said, it's great that you're looking at drugs, it's great that you're looking at ventilators, but the most important resource will be human resources. And there is no way that we can find specialists just in a few weeks. But what we can do, if public health measures are not sufficient, is actually use those human resources that unfortunately have to be deployed because other clinical activities stopped. We say that should not be our first goal. The first goal is to stop the spread in the community, and we are big advocates indeed for vaccinations now for everyone. But when an outbreak comes and you have other healthcare workers not working regularly in intensive care, coming to help in the intensive care unit, maybe we can do something for those people. Maybe we can do something for those healthcare teams. And that's providing some knowledge for some basic skills in intensive care. This is the background behind what I think has been the largest training program done for healthcare workers during an healthcare emergency in Europe. It's called C19 Space. It's a training program funded by the European Commission, and that I had the honor with the European Society of Intensive Care Medicine to plan and to deliver. The goal was to train at least 10,000 healthcare workers not working regularly in intensive care. I will show you some data later, but now I have a very short video that tells you a little bit what this program is about.
We cannot be unprepared twice. Prevention does not begin at the gate of intensive care, but at the community. That's why we need all your help. We need a healthcare army. Welcome to this immersive learning experience of C19 space.
Following this program will really help them to get an idea of what working in an ICU is like, and to really be immersed in the basics of learning ICU skills.
Basic training so that people get accompanied or accustomed to how an ICU looks like, what is expected from them, use stuff around, and there will always be ICU stuff around to support you when you call for help.
This goes into much more detail and provides key learning objectives and also some assessment to test knowledge. That hasn't been easy to do during the COVID period. Pulling together different individuals from different countries, all with a common aim. So I think that's been very valuable.
Exciting, innovative, and portable.
It's incredibly positive, coming at the right time, and if we can use it and build on it, it's fantastic.
It's very innovative and interesting to do it. So let's do it.
The goal really was to get ready together and to bring more psychological safety, more ways to work in a less stressful environment, because it has been a very stressful period for every healthcare worker working in this situation, not just in intensive care. I really have to thank every colleague from every other department that has to come and help in our intensive care units. And I think when you invest in human resources and in knowledge, it helps also people to work better, to feel more safe in the team, teams to work better, and that ultimately can also prevent burnout, which we know is being, and it is a major issue now for many healthcare workers around the world. So the goal was to train 10,000 people. Actually, we went above that. There was a big reception of this in the European Union. We have more than 20,000 healthcare workers involved, nearly 3,000 trainers, and we had more than 17,000 healthcare workers not working regularly in intensive care that have been trained that could benefit from this program. So if I can say, this for me was a great project to lead, but also I'm very grateful to the European Commission for funding this, and now we hope that we will be able to extend this program even more and to help even more people. So I'm concluding my presentation with this, and just to send a message and to ask everyone really to help us in the intensive care and in the hospitals. We are not going to win this battle with COVID just by increasing ICU beds. Every time you increase an ICU bed without human resources, you're stopping other activity, which is not fair for other diseases. So really vaccination for everyone, healthcare workers, for the population, doing this is crucial. And I think also in the most privileged parts of the world where we are lucky to work, I think also we have to make a plea to give a fair access to vaccinations to other parts of the world, healthcare workers and population. I think it's fair to do so, and it's also something that we have to do if we have to stop the development of new variants. And with this, I would like to thank you for your attention.
So much, Maurizio, for your presentation, but mostly for all the work that you have done and all the courage that you had during these difficult times. And I congratulate you also for the work of the European Society of Intensive Care Medicine, because you have done an amazing work during all this time, showing that this European cooperation is possible And it's possible also to change the way that we train healthcare professionals and actually to partnership and work together. Thank you so much. From the intensive care, we go to the long-term care. That's another area that we need to focus. Actually, another very fragile area during these COVID times. And I'm happy to introduce you to Dr. Adelina Comas-Herrera. She will tell us about the impact of COVID on long-term care services. She's an assistant professional research fellow at Care Policy and Evaluation Center at the London School of Economics. And she's also the curator of the website ltccovid.org. And I invite you also to visit it. It's an amazing work. Adelina, the floor is yours.
Thank you so much, and thank you for inviting me to be part of this panel today. So as for the introduction, I am part of a group of experts on long-term care that have been keeping track of the impact of the pandemic on people who use and provide long-term care all over the world. And we've been documenting and sharing this through the LTC COVID initiative, and we're continuing to work on this to ensure that we learn the lessons. And as per in intensive care, it would be difficult to overstate the huge impact that the pandemic has had on people who rely on care and support from others. And what we call long-term care, social care, this can happen in nursing homes, but it also happens mostly in people's own homes through care provided by unpaid carers as well as some professionals. So if we look back at the beginning of the pandemic, it became clear very early on that very few countries had pandemic plans that included measures to minimize the risks to the population who rely on care from others due to health conditions like dementia or other causes of disability. In fact, in many countries, what happened was that the pandemic plans had identified nursing homes as a convenient or easy place for rapid discharge of people who are still infectious with COVID-19. And that really shows the lack of understanding of how difficult it is to stop the spread of infections in a place like a nursing home, and the fact that most people living in care homes are very old, frail, and have multiple comorbidities that put them at increased risk of dying if infected from COVID. By March 2020, the official death counts for COVID of most countries did not include the vast number of people who were dying in care homes. So we were counting only the deaths of people who had a test. So that helped to hide this enormous problem that was growing, and we were learning about it from newspaper reports. And what we saw was that there were numerous examples because of this of people living in nursing homes that were being denied hospitalization just because they lived in a nursing home. There was no time perhaps to take into account their individual health status, the potential to benefit from treatment. This was not a generalized fact, but it was a really important symptom of what was happening. We also saw do not resuscitate orders being given without consent of either the person or their relatives. And we also did see that many people who died from COVID in care homes were not able to have a minimally good death. They were not accessing palliative care, they were not accessing oxygen. What we also found was more generally was that care homes in most European countries were struggling to access testing, personal protection equipment, were given inappropriate and rapidly changing guidance, were losing their already scarce healthcare trained staff to the health sector because of the emergency. And what we were then seeing as well was that in the first wave in Europe, about half of all COVID deaths were happening in care homes. But things did get better and notice was taken. And by September 2020, European care homes in Europe had better guidance, much better access to regular testing, PPE. There may still have been problems, but there was a big intention to support them. There were surveillance systems being developed to monitor infections and deaths in care homes, and data was reported regularly in many countries. And I'd like to praise the European Centre for Disease Prevention and Control for their major role here. We also saw great innovations to respond to the crisis. Much better joint working was developing. We saw the use, for example, of telemedicine to facilitate access to clinical support for care homes. We also saw that in the data that although there were still a lot of deaths because the second, third waves were very big in Europe, we saw that the share of all deaths where care home residents was lower, was between 30 to 40%. And we're doing some analysis of this data. It's really difficult to attribute causation and to say exactly what was happening. But we can say that we estimate that thousands of deaths of care home residents were prevented through better measures in the second and third waves. But overall, the impact has been enormous. By the time that we started to have the first vaccinations in care home residents in Europe, about 1 in 20 care home residents had died in some countries from COVID. Now, finally, the vaccines have broken this what looked like a really stubborn link between infections in the community and deaths in care homes. And of course, I'd like to highlight the incredible achievement and effort that has made this possible. However, what we are seeing as well is that many people living in care homes are still facing huge restrictions in their freedoms, and that many people working in this sector are still struggling with burnout and very significant trauma. They've seen their colleagues, the people they cared for, the people living in the care homes, they've seen people die around them in ways that perhaps none of us would like to ever experience. And we still have very little information about how the families who provide care at home have coped and have been impacted by all this. Because they were even less visible than those in care homes, more difficult to count and more difficult to reach in accessing support. And where are we now? So we are seeing that long-term care providers all over the world, this is not just a European phenomenon, are struggling to have the staff that they need to function. Many of the staff, as I said, are suffering from burnout, trauma. Many are finding that the health sector, the traditional health sector offers better pay and better opportunities for career progression than the long-term care sector, as well as better recognition. We know, of course, that there are shortages of workers in many other sectors that pay better and offer less stressful jobs. So what can we learn from all these, and where do we go from here? And I'm not going to give you an easy answer, because we know, and we've known for decades now, that to have care systems fit for an aging population is urgent. It's something we need to do, we need to achieve, and we haven't really done it yet. We haven't got there, at least on the long-term care side of things. In many countries, people with long-term health conditions like dementia, disabilities are having to bear enormous financial costs to meet the costs of their care. And this care is often precarious and it can even be unsafe when the regulation systems are not strong enough. We also find that when people are outside the healthcare system and perhaps don't qualify for social support, they're also not counted. We don't have information system that enables us to know how they are doing. These people are having to navigate a really fragmented, uncoordinated, complex system that was brought to light as well through the pandemic. And this is just to meet their basic living needs. So I'm going to make a plea that we really work hard to try to persuade and to try to understand how is it that we can fully include people with long-term care needs in universal health coverage. We know that this would only cost a few, and very few, 1 to 2, perhaps in some countries, percentages of gross domestic product. It's not very expensive to do this compared to how much we spend in total public budgets. This would not bankrupt any country. I'm an economist. I've been looking at projections of future costs for long-term care for years. And we know there are a few European countries that are actually already funding long-term care much better and that we can learn from. And they seem to be functioning very well in good financial health, relatively speaking. So I don't know why it is, but we do seem to have this cycle where low funding is leading to low expectations, and perhaps this is putting long-term care very low in the political agenda. It has come up during the pandemic in a very dramatic way, and I think we now have a duty to really make the most of learning from this very traumatic experience and make sure we have something better. I'd like to end by reminding that a strong, well-funded, well-staffed long-term care system, well coordinated with primary care, acute care, public health, and social protection is an essential part of what we need to make sure that we can all aspire to live well and age well, contribute to society, and ensure that no one is left behind, even in a pandemic. Thank you very much.
Thank you, Adelina. And actually, this is that you raise great points for us to discuss. And I invite everyone to use our chat box in the right of your screen to make some comments and questions for our speakers. I will now invite Dr. Ellen Coleman to join us. She's a senior researcher at Hanover Medical School, and she's also the president of the UFA section on health workforce research. So we came from intensive care, long-term care, and now health workforce research. Ellen, you are a good friend of Emma. Thank you so much for joining us. The floor is yours.
Thank you very much. So hello to everybody, and really my big thanks to Emma for organizing this session and for inviting me. And I'm really grateful for this opportunity to highlight the importance of the health workforce and healthcare workers. Healthcare workers are really at the core of every healthcare system. And in a previous statement, the regional director, Dr. Hans Kluge, has highlighted that we do not have a response to COVID-19 if we don't care for our healthcare workers. I could not agree more with this. But also, I'm very grateful to the previous speakers, Mauricio and Adelina, for raising these healthcare workforce issues. And I think there's little which I could add to this. You really made it very clear how much burden it means for the health workforce in different areas, in different ways, but they are all affected by the COVID-19 pandemic. And what is especially important, we should not forget how many healthcare workers died of the pandemic. And this means there is really a responsibility for us, because protection can be improved. These deaths, many of these deaths, not all, many of these deaths would have been preventable. And that is a very serious issue for everybody who is working in this area, for policymakers, for managers. It is not, at the first instance, the virus that kills healthcare workers. It is poor governance, poor policy, and poor management. So I know this is a very provocative statement, but I think that's the way it is. And let's have a look now what can be done. So of course there is no solution and there is no one size fits all model, but there are some things that we learn from the literature more generally. And I would like to raise 4 major issues. So the first thing is there is a need for new policy priorities and for what I would call a cultural shift in health policy. And that means, my previous colleagues that you already mentioned, that it's not enough to look only at machines. It's not enough to look at hospital beds only. There is much more what healthcare workers need. And last year, I worked with WHO and the observatory with the support of UFA on a special issue, which we called the human face of the health workforce. And that is what I think is very important for everybody who is working in that area, to better understand that there is indeed a person behind every healthcare worker. Healthcare workers are not just numbers for planning. Planning is important, and healthcare workers are also not just a search capacity, which can be increased as we can increase hospital beds and other facilities. So, and if we understand that there is a person behind, and this person has needs, and we should listen to these needs, then it would help a lot, and it would shift the policy priorities. And maybe some of you attended the current WHO assembly yesterday, where the mental health topic was raised by Dr. Natasha Padimaskat and others. And I think this is important to understand that mental health, more support for mental health must also be applied to the health workforce. And again, I'm grateful to the previous speakers that you already raised these issues. So if we are looking at the person behind the healthcare workers, my second point, that also brings us to gender inequality and discrimination, harassment, violence. As we know, all of you know, I'm sure, the majority of the health workforce is women, and women have been affected the most by this pandemic. So still there is gender discrimination, violence, this harassment is very strong, and it is all too often tolerated, at least in the healthcare sector. So we must stop that. We must improve the work conditions. We must improve respect and opportunities for women. Third, also related to the person behind the healthcare workers. High percentages of the health workforce are migrant healthcare workers, or especially in the long-term sector within the European Union. We have this mobility. So really mobility flows, that the flow is from the east to the west. The flow is always from the low resource setting to the high resource setting. And during the pandemic, these migrant mobile healthcare workers have been the most vulnerable, and they have been nearly forgotten in the policy debate. There hasn't been specific policies or specific attention to this group during the pandemic. The problems are by no means new, and they are by no means only related to COVID-19, but as in many other areas, COVID-19 has reinforced the need to act. And I think that is really important to improve the integration of the migrant healthcare workers, but at the same time to stop unethical recruitment. This is really very important. We should no longer do this, and we should no longer tolerate that in the European Union. There is a strong need for solidarity-based regulations within the EU, but also globally. And my fourth point, looking more closely at strategies. What can be done on the organizational level? And most recently, I did with colleagues from the UFA Health Workforce Research section, we support from UFA what we called a quick assessment of prepared and protection of healthcare workers during the pandemic in the European Union. And we looked at 4 different countries, including Romania, Portugal, and so different, also Germany, different, and Denmark, different regions, different situations. And we surprisingly found a common trend that all countries, in different ways, but all countries had really improved efforts to prioritize the vaccination of healthcare workers, to improve the protection on the level of personal, of PPEs. So, and Adelina also mentioned that there has been improvement in the long-term care sector. This is very important, but it is not enough. We also found a common trend across our countries that there is governance gaps in all countries when it comes to mental health, when it comes to social support services. So, and there is therefore a very strong need to look also at these areas, to invest more in the health in a more comprehensive response to the COVID-19 pandemic, and more comprehensive strategies to protect healthcare workers. What does it mean for us now? And I think the most important lesson from this is that we act now, that we do not wait any longer, that we really pay attention to the health workforce. And as as you know, there has been the health workforce, healthcare workers have received more appreciation at the beginning of the pandemic, but it's not enough to clap for healthcare workers. It is quickly forgotten. This support for healthcare workers is already now diminished, I think. So there is a need for really serious action for prioritizing the health workforce, for developing more comprehensive, complex responses that take gender inequality into account, that take responsibility for migrant health workforce, develop solidarity-based approaches that improve mental health and social protection services, that prepare really healthcare workers to respond to the pandemic, to develop long-term strategies. And I call on all health managers, regardless whether in hospitals, in long-term care or in primary care, take this responsibility. Start now, start somewhere. Listen to your healthcare workers, what are actually their needs, and develop jointly with them responsible, effective, supportive strategies. So thank you very much for your attention.
Thank you, Ellen, for your great presentation. I will now take the opportunity to see if you can hear the message from Dr. Hans Kluge from the backstage. If it is possible to listen to the message, we will have that opportunity now.
Dear colleagues and friends, shocks and crises trigger change. COVID-19 is no exception. It has let bare flaws in our systems and provided us with a unique opportunity. Last week, the Pan-European Commission on Health and Sustainable Development, established by WHO Europe last year, chaired by Professor Mario Monti, called for an urgent reform of healthcare. Its actionable recommendations give decision makers, academics, and health leaders like you tools to prevent and better handle future health threats. These are recommendations that save lives and livelihoods, trigger innovation, and empower people. Nearly 2 years into the pandemic, there are countless lessons, some painful, some timely, but also accelerated progress and breakthroughs. Think digital health. Think of today's broad understanding of health being cross-cutting. Think of the general acknowledgement of conditions and contribution to society of the health workforce. The word resilience is now a buzzword. While the term is borrowed from ecology and psychology with regard to measuring a system or individual's ability to absorb and bounce back from a shock, its application to the area of health system strengthening and performance continues to be refined. Without going into the resilience literature, based on a forthcoming volume of health system resilience by the European Observatory on Health Systems and Policies, let me highlight the following. First, resilience is typically focused on understanding health system preparedness and ability to absorb and transform to cope. Second, the health system response to a shock can be understood as doing things that ensure sustained performance of system functions. Third, health system resilience can be viewed as something that goes beyond what it was before, possibly neither feasible nor desirable, including an ability to evolve and learn, improving future performance. Learning from a shock and preparing for future ones is often neglected. Once the shock has passed, decision makers tend to revert to dealing with day-to-day system strains and stresses. This time around, we cannot allow that to happen. To support resilience, WHO has two priorities. One is to finally put primary healthcare at the heart of our health systems. Primary healthcare has played a dual role in the pandemic. While responsibilities and demands kept growing, primary healthcare delivered essential health services with renewed efforts. In many countries, primary healthcare supported the pandemic response through community surveillance, testing and contact tracing, management of asymptomatic and mild cases, and rehabilitation of post-COVID conditions. Overall, this led to a dramatic increase in responsibilities and workload at the primary health level and prompted transformation. Country experiences reveal the potential of proactive, people-centered primary healthcare to address a wide range of conditions. They have also demonstrated the ability of providers, people and systems to adapt to new approaches and ways of delivering and receiving services. Strong primary healthcare must be the backbone. This was first laid out in the Alma Ata Declaration in 1978, again in the Astra Declaration of 2018, and now the pandemic has revealed the true potential of primary healthcare and hammered home a message we cannot ignore. A second priority for health systems that WHO Europe actively supports is to overcome the somewhat artificial healthcare social care divide. Modes of organization, financing and delivery often differ between the two. But from the perspective of an individual patient, continuity of care and a seamless transition is expected. We need to support the integration of services and interoperability of systems, even within the healthcare realm itself. But resilient systems from a patient perspective are ones that treat the individual on a continuum of care and do not expose them to potential vulnerabilities and poor outcomes. Nowhere is this clearer than in respect of mental health. Already a substantial challenge in public health and economic terms, COVID-19 has greatly exacerbated mental health conditions and prompted major changes in the demand and delivery of services. Globally, we anticipate a steep rise in mental ill health, and we can only be up to the challenge if we overcome this divide. Finally, a key issue for health systems post-COVID-19, something that was glaringly absent from many preparedness plans, is the need to recognize and account for social disparities. COVID-19 has leveraged disparities. If a preparedness plan is to ensure protection of the most vulnerable, addressing the root causes from the outset must be a given. This we have not seen. The pandemic has amplified the need to take action on social and economic determinants of health. Build back better, yes, but this must include build back fairer. What we need going forwards is a multi-sector health protection and promotion approach to be at the heart of the pandemic responses and health systems. In closing, I'd like to encourage you not to lose sight of the silver lining of COVID-19, to implement timely changes of health systems, adapt new technologies, to look forward, not back, because now there is the momentum. Thank you for the opportunity to be with you today. I wish you a fruitful day, full of inspiration, followed by action. Thank you.
Thank you. It was a great message from Dr. Hans Kluge, and actually quite inspirational also as the talks and the presentations from our panelists. We have now the opportunity to check the comments and the questions that you have gave us during the presentations. You can still use your chat box to make some comments, questions. Actually, we have a great engagement on our chat box. And I will start by Damien Graves. And I think it's actually it's cross-sectional to all of us, is that this issue about fragmentation. Actually, Dr. Kluge mentioned that is not only a fragmentation within the health system. It is a fragmentation also with social services, and we have the opportunity to deal with it. Adelina, I will start with you. I know that this topic is very important to you, and I will give you the floor to comment, but I will follow with the other panelists.
Thank you very much. And yes, it was really important to hear how Dr. Hans Kluge emphasized the importance of having continuity of care from the point of view of the person. People who have a disease, a condition, they don't, for them, it shouldn't matter whether their needs are to be dealt with in acute care, in primary care, in a long-term care setting. We really need to sort this out. And I'd like to call for, and I use this opportunity to say that in the same way we're looking and analyzing healthcare systems, and we have really good investment in tools to share the experience of how to improve healthcare systems. We haven't really had the same effort and the same resources and platforms to do this yet, to cover the long-term care systems. And I hope we use this opportunity. There's been a lot of work that's been put in place by experts in this area. There's been a fantastic coming together of people who are looking at the financing of long-term care, the delivery, the regulation, how to integrate when we have different systems. What are the data systems that will enable us to find the same person as they move from one type of service to another, and how can we have all that in place? And I think this is a great opportunity. It's been tragic, but as Dr. Hans Kluge said, we need to use this momentum and not lose this chance. Thank you.
And actually, it's time for action. Maurizio, Ellen, do you want to make some comments on this? Starting with Maurizio.
I think we all agree with what we said. I think the challenge is going to be now on how do we transfer to actions these ideas, because I remember after the first wave in Italy and in Europe last year, we were saying we cannot be unprepared twice, but unfortunately we've seen that we were better prepared, but we were still unprepared. And I think it would be unacceptable not to put instruments. We talk about resilience, but I think it's also flexibility on how to respond to future healthcare threats, because we have to be careful that we don't have a tunnel vision now about getting ready for the next COVID pandemic, because maybe the next healthcare challenge in 10 or 15 years will be a different virus or a bug due to multi-resistant bacteria. So we have to create this flexibility in the way we respond to this, and also how we help each other cross borders, without forgetting that healthcare workers are humans, and to think that we can sustain the energy of a sprint for 2 years in a row, it's just not acceptable, and it's just not feasible. And if that happens, unfortunately, even the quality of care will decrease, as we know. And when you decrease quality of care, you start to see moral distress and moral injury in healthcare workers that always want to care at the best level for patients. It becomes a little bit of a vicious cycle that I think we have to break. And I know it sounds maybe strange from an intensive care doctor at the front line to say, if we have to invest, of course we have to invest in capacity for intensive care, but the biggest investment should be in avoiding the need for intensive care. Even in the best intensive care, units in the world, unfortunately, you don't have 0% mortality. And even if you survive intensive care, it still takes months, sometimes years, to go back to a good quality of life and to independence. Sometimes it's not even possible. We studied with our group, for instance, that after being admitted with ARDS, the return to work of patients was not always possible. So I think we need to see the healthcare as a continuum, and the best way is really to invest in prevention and containment in case we have other healthcare threats. Hospitals have to be ready for immediate threats, like a mass casualty event or an initial pandemic, an initial outbreak. But ultimately, the real investment has to be in a structure to monitor and stop hospitals being overwhelmed. Because if hospitals are overwhelmed, all the society unfortunately stops, as we say.
No, thank you, Mauricio. But it's not only for COVID. The issue now, and I will also like you to address it, even from the message from Dr. Kluge, the question about social disparities. And actually what he's saying is that something like build back, but build back fairer. In that sense, of course, even when you were saying about prevention, we really need to emphasize the importance of prevention, even dealing in social disparities, to deal with social determinants. Ellen, what is your comment on this?
Yeah, thank you. So I would like to share with you a vision, because, and I agree with what you all said. I believe it would already help if there is a strong policy or that's what I meant with a culture change. That always, if we talk about health systems resilience, we must also include the health workforce. I have had a look at quite a lot of the high-level meetings, the statements, and so, and they made important issues. So I'm not totally complaining, but you will certainly agree, many of them miss the health workforce. Sometimes they mention that in one sentence, but as search capacity, not as really people. And if there would be an obligation and a responsibility, always if you talk about healthcare systems, that you include the health workforce, then that would be a big step forward. And one issue is to lobby for a high-level commission, for high-level support, for better networking. And I think even what you are doing with your session now, it's not taken for granted that the health workforce gets so much time in a health system and management session. I think, to be honest, it is an exception from what I observed. So that can be a step forward. My vision is to improve our networking, to improve our lobbying work, to work together and really try that on the European level, with the support of WHO and EMA and UFA and the other organizations, a high-level commission will be set up that looks at the health workforce across all sectors. That is really extremely important. I don't want to repeat that. The two of you already said that we look at all areas and stop this hierarchy between the health workforce. But the second one is that we start also bottom up, and there health management can do really a lot, because many of you are in leadership positions. So, and it helps to start just somewhere and to start with listening to your healthcare workers. So that would be my main vision for the future.
Oh, thank you, Ellen. Let me just go back to a comment from Sandra. I believe that she summarized your previous intervention, COVID, and she's saying something like COVID, mental health, migrants, healthcare workforce. I think it sums your comments, Ellen. And actually, now we face all these issues, not only struggling with the lack of human resources that we have in long-term care. It is clear that we don't have a workforce for long-term care, for social services. We are relying on migration. We face this migrant waves from south to north, east to west. All the countries are facing shortages in healthcare workforce. What can we do? And just coming back to the action, what is actionable? And for all of you, what can we do next to shape health systems and not waste the learnings from this COVID times? I will start with Adelina.
As you were going to ask the question, the one word I wrote was that we need a new approach to healthy aging, and I decided this is where a lot of the pressure on our systems may be coming through. And I don't think we're doing a very good job in most countries. In most countries, people who have longer term needs don't get much rehabilitation, don't get much support to live independently. Many people are ending up in care homes that if they had adequate support in the community would not be there. There's very little work together in rehabilitation in the community for the people that might be preventing some of this more intensive care that is needed later. There's a few countries doing that well. There's some really nice examples from Denmark, for example, and I think we can really learn from this. In Denmark, before you're getting a care package, you're going to get a rehabilitation package to see how much you will really need after that. And that way we're not placing people in a higher state of dependency unnecessarily. So really can do something much better than we are. It requires imagination, it requires collaboration, because typically the staff in long-term care are not trained in rehabilitation, don't have the tools for that. So I think that we have a huge opportunity to do this better. We need political will, but we also need, I think, to be able to flag these good examples, to present a positive view of the changes that we want to achieve, to show that better trained care staff can do much better. And if they're doing much better, can we also pay them better? Can we make the claim that these are important jobs, and that important jobs that need to be rewarded, that people can get further qualifications, further recognitions, have a career progression, and that this is an important and very skilled job, even if quite often people don't require a lot of formal qualifications in the way we are organized. So that would be my suggestion for now. Thank you.
Oh, thank you, Adelina. Just to go back to the comments, and I will back to you, Mauricio, but just go back to the comments. There are some suggestions regarding gender issues. I believe that I think it was Eva that suggested also the global health for women, or women in global health, that's more correct. And also we have a website that is healthworkforce.eu that you have some different European projects. It was a suggestion from Esther Kovacs. Maurizio, actions to reshape this COVID time.
I think if we want to move to actions to this, I think we also have to deal with the policymakers, and maybe, also European or wider institution could help with some direction on also how the funding of healthcare system should reward what we said. Because it's very easy for us to say we need to focus on prevention and we need to look after the healthcare workers, but at the moment, funding is actually following activity and stretched hospitals, and the more you make a bed working, the more funding attracts in the majority of countries. So if we all agree that prevention is important, if we all agree that it is important to build some spare capacity, and maybe that maybe 20% free hospital beds is not a waste, but it's something that allows you to do better quality, then we need to find incentives to reward that spare capacity, that prevention, and also the way we look after healthcare workers. Because now we have this situation which maybe is not very clear to everyone, but every time we have an outbreak, healthcare workers work very hard. But when the outbreak goes, they don't go on holiday. They actually have to catch up with the backlog of all the other elective activity that has been stopped. So I speak on behalf of many colleagues around the world. I know that we've never worked so hard like in the last 2 years, even outside of the outbreaks. And so I don't think it's only paying more money. I really think it's about rewarding systems that look after healthcare workers, also by allowing time off, by allowing a more healthy way of working. And that's why if we just focus on how to increase capacity and resilience on the healthcare system, I think we miss the point that really the biggest thing we should focus on should be prevention and long-term good working condition to provide the best quality of care to all patients. And funding has to follow that strategy. Otherwise, there will always be a conflict between what we think as an ideal can work, but how, unfortunately, then hospital management will be forced to work.
Thank you, Mauricio. Actually, this healthy environments, it's not only for the population, it's also for healthcare workforce. And occupational health is quite relevant in health provision settings. Ellen, you are the advocate for a healthcare workforce at European level. Actionable points to move forward.
Yeah, thank you. I must say that there's very little to add, as my colleagues already made these strong points for the health workforce, which is really, I'm so pleased to hear that. I would like to take on from Mauritius' suggestion or Mauritius' comments on the 25 or 20% beds in hospitals to understand that it is not a waste. And I would say yes, but why not then say we need to understand that maybe not 25% reserve of the health workforce, that's not realistic, but that some reserve of healthcare workers is not a waste, but it is absolutely necessary to sustain the health workforce. Absolutely, I think, because as I don't want to repeat that because Mauricio already explained that healthcare workers are absolutely at their limit, and I think in all areas, totally. And if we continue with this, then we will experience for sure in the near future, and especially in the more middle and long term time, we will experience a totally dropout, a very serious dropout, because some of the healthcare workers will drop out because they are simply ill and burned out, and the others, especially the young one, will say, am I crazy to go into that area where I will come out with 30, 40 years and so I'm totally burned out, mentally ill, not knowing what I can do. So, and healthcare workers don't build up millions in a few years where they can live for the rest of their lives, as you know. And I really think that is for me the important thing, that we understand why do we have a reserve for beds and not accept that we need a reserve, at least a small reserve for healthcare workers. I think that is really very sad, but that is the reality. And I'm pretty sure if you go to any health minister in your country and say, look, I need a reserve of, let's say, even 5%, which is much lower from the beds. I need a reserve of healthcare workers, and I need a new finance scheme that takes that into account. They would say, are you crazy? So you will never get that. They may not even listen to you. And that is something that we all should stand up and no longer accept, because we treat healthcare workers still as machines. And from time to time, if we think it is good, we make them heroes. Heroes are always easy, and most of them are dead, as you know, so they can't complain any longer. We don't need these heroes. We really need policies and management that take healthcare workers seriously. And this idea with a reserve, take that seriously, I think that could be an important issue also to open the eyes of policymakers and also the general public. Yeah, thank you.
No, thank you, Ellen, for your inspiring talk. We are now at the end of our time together. I will thank you so much for your participation. Let me just summarize some key message. The issues about healthcare workforces, even in our comments, it's a topic that we need to address: attractiveness, retention, not to forget the training of healthcare workforce on long-term care. Also the need to integrate better our services, health services, but not only, also social services. Again, not to forget long-term care. I'm receiving a commission from Adelina or talking on long-term care. And also, let me just summarize another point or another key message, that are social disparities, and this issue to build back, okay, but build fairer. And there, it's not only about dealing with barriers to healthcare, it's also to have a proactive health system where prevention takes the lead and healthy lifestyles take the lead. So thank you so much for Adelina, Maurizio, Ellen, for your great participation, your insights on reshaping in this post-COVID world. For our participants, we will now have 1 hour lunch break. You can also, during this time, join us during the poster sessions. But again, you can go for a lunch or for a stretch or for a walk. And in 1 hour, we will meet again with the other sessions. We have amazing researchers that are presenting their oral communications during the abstract sessions. And we are hosting also some interesting workshops that I invite you to participate. So I will invite you also to use our platform, networking with our speakers. All the comments that weren't addressed during this panel, you can use the platform to network, to talk, to discuss, to chat. Use it because it's interesting, and you can have this opportunity to talk with these amazing speakers and with each other. So I will welcome you also to the expo area in our platform, where you can see also and engage with the sponsors and the supporters of our conferences. So thank you so much for being with us this morning. Have a great lunch. For those who are more resistant, go for the poster sessions. Thank you so much, and see you in 1 hour.